અને ઇન્સ્ટામાં બી ચાલુ કરીએ. હા
પેલા મેડમ છે ને એને ખ્યાલ આવી ગયો.
યા એક મિનિટ. હા થોડું પાછળ રાખજો. શું આવા દે વાંધો.
સ્ટાર્ટ કરી દો.
હા કરી દો.
અંદર કહી દો
ચાલુ કરીને 2 મિનિટ વેટ કરજો. કેમ છો મજામાં? જો વોર્મ વેલકમ. લેટ એવરીવન જોઈન. આઈ કેન સી સો મેની પીપલ જોઈનિંગ.
ઓકે
કરીને ચાલુ કરજો.
ઓકે. મોર પીપલ ઓન ઇન્સ્ટા. ચાલો.
સ્ટાર્ટ કરો.
ઓકે.
સેલ્યુલર ડેટા હોય છે.
બધું ઓન જ છે. કેવું લોગિન છે? કેટલા? Let me see. So we start in a couple of minutes. Meanwhile, all of you can just type in your questions in the chat box. It will be a good way to start. Hello. Good afternoon, Dr. Shweta. We'll just wait for a minute or so and get colleagues on board. Good afternoon, Dr. Sunita. Yes, Dr. Hitesh, we'll just get used to this medium. Let me know if there is a problem. We are also live on Insta. So anybody wants to join in from Insta, welcome to do so. Thank you so much. Okay, so I think we are quite a few of us and we start our session Let's keep this as a Q&A session on fevers, because this is a full fever season and last 2 years have been a full fever year with COVID. So I'm sure all of us have a lot of experience handling fever, succeeding in fever, failing in fever, managing fever. So you can go ahead, maybe share your experience or put up a question, put up your difficulty that you have faced. Most welcome to put up anything. Yes, Dr. Shweta, you have any questions? Dr. Sunita, any questions that we can start with? So I don't want this to be a lecture. So it would be good to have some questions. Have you received some questions on Insta? Okay. Okay. So let me start and see if we get more questions in between. So majorly fever has been a challenge for most homeopaths, whether you are a junior, whether you are a senior homeopath. So fevers have been challenging. So, and why they have been challenging? Let us understand this and put a perspective to this. First thing, let us understand that fever is a symptom. Okay, Dr. Shweta, I read your questions. I will take it up. So, fever is a symptom of something that is more primary, the real pathological condition. It can either be acute or you can have a chronic fever. So, the approach in both these situations is going to be very different. Fundamentally, when we are faced with fever, what is going to be vital is to understand whether this patient has an acute condition or he has a chronic condition. Recently, I had this patient who says, I have fever since the past 2 months. Every evening, 9900. All investigations don't yield anything. What we know classically as pyrexia of unknown origin, PUO. So, the approach to a patient with PUO is going to be different than an approach with a patient who probably has malaria or COVID or has typhoid. The approach is very, very different. Also, in terms of the approach in the follow up. What is it that you are going to follow up after you make the first prescription? What are the criteria for follow up? What are the parameters that you are going to say that these are the parameters that I'm going to watch for in the follow up? So, this is one aspect that requires a lot of clarity, and this is where often the clinical diagnosis of the fever becomes very vital. Often, without a clear diagnosis, it becomes difficult to choose the approach to create the totality in a particular case, and then obviously to find the remedy, and in the worst case situation, to then look into the follow up. This is one thing, this clutter in our heads makes approaching fever cases difficult. So, this is what we have to cut through. Define the nature of the fever, the diagnosis of the fever. Because the diagnosis is also going to tell you what response will you expect. For example, if the patient comes with malarial fever and I prescribe the remedy, then I would expect that the next spike of fever would be less intense, less duration. This is what is my expectation in a case of malaria after I make the first prescription. If it is a case of typhoid, proven enteric, which usually happens in the second week, then my expectations are different. After giving the remedy, I will have to observe how the fever begins to go down. Even within the fever, you are going to have diurnal variation. What is a diurnal variation? Different times of the day, the temperature is going to be different. Usually, the morning fever temperature is lower than the evening ones, right? So, if it is a case of typhoid and I have established the diagnosis of typhoid, then what I am going to watch for after the remedy is the evening fever. I will compare the evening fever. If the evening fever starts dropping compared to the earlier days, then the remedy has probably acted. So, this is the second situation. The third situation is a situation like dengue, where you know that the fever normally goes away in 4 to 7 days. So, what am I going to do? What is it that I am going to follow up with? So, what is important then in a situation like this is the duration of the total duration of the fever, the other associated symptoms with the fever. You may have headache, you may have vomiting, you may have loose motions, you may have abdominal pain, you may have cough. This is important that you have to look in a 360-degree manner. The third situation is something like tuberculosis, where you prescribe the remedy and you don't expect the fever to go away in 2 days. But yes, in a week's time, the fever, 2 weeks' time, the fever should begin to touch normal. This is going to tell you the response of your prescription. So, and yes, another condition, when you have an autoimmune disease where fever is associated, then the situation is very, very different. Fever is going to be one important part along with the laboratory parameters talking about the disease activity that we need to figure it out. So, This is broadly how I see fevers. I will try my best, and I will definitely go several steps to establish the diagnosis, because that establishes the clarity in my mind, for which your training in internal medicine will be of utmost importance. What investigations to order, when to order those investigations, and how to follow up with those investigations become very critical. So there is one question: treatment of dengue fever with thrombocytopenia and leukopenia in homeopathy, in home setting with homeopathy and ancillary measures needed. Okay, is this a question or it's a statement? Well, okay, I assume it's a statement. Okay, then I take up Dr. Shweta's question. She is asking how much importance should be given to the thermals of the patient. Now, thermals in the fever, that is what we have to understand. Thermals in the fever become important when they are altered since the onset of the fever. Just give me a second now. Okay. So, okay, where was I? Okay, so the thermals have to be altered from their basic state. If they are altered significantly, clearly, then they are important. So I remember this formula for an acute case or a chronic case, for a fever case, no fever case, SIP or SCRIP script. SIP spontaneous, intense, and peculiar. And if I say script, spontaneous, consistent, repetitive, intense, and peculiar. If the symptoms, thermals, are any of these, then I will give importance to the thermals, whether it is a fever case or not a fever case. So, for so I, doctor who have asked me this dengue fever question, I don't understand your question. You'll have to reframe it. This appears like a statement to me. Okay, so it is important that before we really begin to handle fever cases with lot of consistency, we will have to be thorough with the fever aphorisms that Hahnemann has talked about, febrile illnesses that he has covered in lot of depth, and one will have to study them in detail and follow them, apply them in practice. That is very important. Also, let me tell you that with the fever cases, the case taking also has to be tweaked a little bit. You will need to tell the patient or ask the patient, tell me what all have changed for you mentally, physically, emotionally since the fever. And we get very interesting responses. You very often you will find children becoming talkative, children becoming irritable, or irritable children becoming very gentle and mild and weepy and more sober. Same thing happens with adults also. That is at the emotional level. Also, what is important is to ask them specifically what has been the change in your thirst since the fever? What has been the change in your appetite since the fever? So, uh, what I normally find when students do the case taking with fever, they will ask the appetite, and patient says, "Okay, I don't feel so hungry," and so they will write appetite lost. But there is a step further we need to go to investigate about the appetite of the patient. You need to ask what happens when you try to eat the food. So often you get very different, varied responses. They will say, I don't even want to see food. I just hate looking at food. I don't even want to drink water. I just don't like the taste of water, but I feel very thirsty. They will also tell you that moment I put it in my mouth, it has no taste. They will also tell you this food tastes very bitter. Or they will tell you that food is tasting more saltier with the fever. So this appetite really needs to be dissected out. They will tell you, I eat a little and I feel I am satisfied, or my stomach feels full. Then you get peculiar symptoms in this area. But if you just ask them, how is your appetite? Most patients obviously are going to tell you, well, I don't feel that hungry. An occasional patient will come and tell you that I feel very hungry with the fever. I remember my own daughter's case when she had enteric. For a week's time, she had low grade fever and she was completely okay, insisted on going to school, do her homework, attend her classes, in spite of telling her that you have fever, just wait. Found that whatever quantity she was eating before her fever, she is eating now also. Now, this became very peculiar. This is relatively increased hunger. Understand? With the typhoid fever, you're eating all the food that is normal in your quantity that you would eat when you are well. So the symptom that we took here was hungry. Hunger increased during fever. Are you getting it? This is also during the fever. Touch your patient during the fever. You will find sometimes, no, it's all okay, no perspiration, no sweating. And when I actually examined this patient, I held that child's hand and the child was sweating profusely on the palms. And then I touched the sole, and even the soles were profusely sweating. And don't get nervous when you're faced with a fever situation. The vital force, intelligently questioning your patients. You will get amazing characteristics is taking out the fever. So, any questions? Yes, any questions from the group? Then I can direct my talk accordingly. The either the paracetamol or anything that they can lay their hands upon, even antibiotics are started straight away. It's a difficult situation, Dr. Vishakha. So what do we do in a situation like this? First thing, ask what is now in spite of the drug, that there are small tiny peculiarities that are present somewhere or the other. This is one part. Secondly, if you feel that it's a situation where nothing immediately needs to be done, you can just wait and observe what is happening. I will choose to wait and observe till a more well-defined, individualizing feature happens. Yes, Dr. Sunita, I'll come out of confidence, and then only you will be able to give confidence to your patient. Okay, so hold the remedy, ask them to observe what is happening, explain to your patient that fever usually is a defense of the body, especially when it is an infective fever. When it is an autoimmune disease, whether it's a chronic disease where fever is a presenting symptom, fever may not be the defense. Okay, so one has to be confident on that. That is where you will gain your symptoms. Stopping, asking the patient before you took the medicine what were the symptoms. So, in the worst case scenario, you will find as soon as I got fever 100, I will take paracetamol. Then I am well. And so then it's a difficult situation. You have to wait through. Sometimes you have to struggle also and see what happens so that the masking of the symptoms don't happen. Okay. So you have to make every effort to get what is called the original unmodified picture. Hahnemann's aphorism in the Organon 6th edition, please read original unmodified picture. In a situation where the patient is too serious and you have no time to wait, with the fever, drugs are given, antibiotics have been given, then in that situation, whatever is there, whatever you get, take it, prescribe on that. That is very important. So I hope, Dr. Vishaka, that answers your question, what we should do when medicines are already being given. So Dr. Sunita's question, uh, so uh, we all know, right, that Hahnemann was translating Cullen's Materia Medica, and that is where he struck upon China and malaria, the relationship between China and malaria. And from Cullen's recommendation, Hahnemann also takes this recommendation forward and says not to administer the medicine during the fever paroxysm. So by and large, I will follow this in an intermittent fever. So when the paroxysm of the fever is appearing or the rising fever, at that time, if it is said that if you give the remedy, you will get a spike in the fever. You will get an aggravation in the fever, which we don't want. So you wait for the paroxysm to get over and start descending down, and that is where you give the remedy in intermittent fever. But in continuous fevers, this rule doesn't apply. Okay. So all these years of past 2 years of COVID, we have prescribed straight away. But usually I will also take care that when the fever is at the lowest, I will want to administer the remedy to avoid the aggravation. Okay, if that time permits, clinical situation permits. So I hope that answers your question, Dr. Sunita. Please read aphorisms on intermittent fever and fever febrile illnesses, paroxysmal and febrile illnesses from the Organon. It's very important that we go by that. Then comes another obvious question. Any questions have come up? Then is another important question: what remedy to use? I mean, sorry, not remedy, what repertory to use? Okay. Now, most of us, till very long, it was me also. So that's why I say most of us use a particular repertory in which we are comfortable or which we know. We don't think much. Every clinical case, because I know this repertory well, I'm going to use this, and there is no other repertory I know as well, and I can't use it. So this point needs to be understood well, that a repertory is a tool. Every tool is useful in a particular clinical situation, and the same tool is useless in another clinical situation. So a situation, how do we define the situation? So for a homeopath, the presenting totality, the type of totality, the type of symptoms in the totality will determine the kind of repertory that you use. Let me explain this a little further. So if you look at typically fever cases, you will find fever as the presenting complaint. Then you have either cough, you have loose motion, you have abdominal pain, you have got chest pain as the associated symptom if the localization has taken place. Along with these core symptoms, these are the main symptoms which helps us to diagnose. So these are diagnostic net of symptoms. Then we have got changes in the generals, if at all, if there are changes in generals. Sometimes no. Then you have got changes in the mental status. So, and then there are cases where you have the core diagnostic symptoms, but you have no change in the generals like taste, thermal, appetite, craving, no change. But there are clear diagnostic symptoms and they express the individuality. For example, I had this child who had viral pneumonia, and on the first day after I make the prescription, he comes back the second day with the fever, and he says that when I cough, I bring out expectoration which is tasting salty. Now I ask him repeatedly, he's a 5-year-old kid, and I asked him in very different ways, is this the real symptom or he's only fibbing about it? And then he tells me again and again repeatedly that this is salty. I said, was it there yesterday also when you came to me? He said, no. And that gave away the remedy. That became my eliminating symptom. In a situation like this, where you have a peculiar, particular, you have a good range of options. Good range of options of repertories that you can use. You can use the BBCR, which is one of the finest repertory for fever. Use the therapeutic pocketbook, which is my favorite and which I have mastered it. You use the synthesis also. You can use Kent also, because here you have this symptom like this, expectoration salty. You may have another patient who comes and tells you that I feel so chilly with the fever, it feels as if my hands or feet are kept in the ice. My hands are becoming cold as if I put them in ice bucket, and then the whole body. Now in this situation, the good repertory to choose can be Allen's fever. If you study Allen's fever, can you get that book? That blue book. Next. Yes. This is Allen's fever, intermittent therapeutics of intermittent fever. And if you see behind is the repertory section. These kind of very strange symptoms belonging to the fever, paroxysm of the fever, you will find best in the Allen's fever. Sometimes you will see, we have read this, no? Postponing chill, anticipating chill. These are great given in Allen's fever, the repertory part. Also, you will find it in BBCR, one of the finest fever repertories that we can have. Then you may have sometimes only fever, the type of fever, septic fever is happening. Then, when the thrust of the case, the totality of the case is dominated by the pathological type of fever, then BBCR is the ideal repertory to choose. You will find symptoms like septic fever, zymotic fever, typhoid like fever, typhus like fever, hemorrhagic fever, all these kinds of fever when so therefore establishing the totality is very important, a clear totality in your mind after interviewing the case. Sometimes you will find that fever is there, WBC count 25,000, and you will have bradycardia. Then the report becomes important, and these are situations where you will find boric very important, where he will give pathological symptoms, what we typically know as pathological generals. If you have the changes in the mental state, then obviously we can have synthesis and Kant. And so depending on your totality and understanding where the characteristic is in the fever totality, you will decide which repertory to use, and not to use the same repertory for every fever. It not doesn't work. So you will have to have this flexibility, and therefore spend time studying different repertories, the fever from different repertories, try and see what comes. When the concomitant symptoms are strong, the generals are strong, I will use the therapeutic pocketbook. It is the finest of the repertory. But when you have this detailed fever paroxysm, no, chill begins from finger, chill begins from eyes, or heat beginning from eyes, in that situation, therapeutic pocketbook will not help. In that situation, I will go to BBCR and I will go to Allen's fever. So variety of tools at your disposal will help. So I hope this also covers another very important dimension, important skill in treating fever. Any other questions anybody has got? I will take up one or two questions and then we can end this tiny session of exchange. Any questions from Instagram? So please take up one repertory, especially the juniors who will have sufficient time in their clinic also. Take one repertory. For example, take the Allen's fever. Study it in depth. Study the repertory in it. Study the materia medica in it. Very, very useful. Study the fever chapter of BBCR, the whole fever section. It gives chill, it gives heat, perspiration, all of this. Spend time sharpening the tools that you are going to use, because very often these are not taught in detail as much as that is required for one's practice at the undergraduate level, and I don't even think it is taught even at postgraduate level. So you will have to study it. Study the therapeutic pocketbook. Okay. So Dr. Mankar's clinic. Yes, my experience in repeating in the fever. Again, crucial question. Depends on the diagnosis. Depends on the pathology that is involved. If I'm dealing with a tuberculosis case, I would love to give LM potency once a day is what I do, and see the response in a week's time. If I'm dealing with something like COVID, I will repeat it 3 times a day. Something like dengue, I will repeat 3 times a day. So one will have to understand. Something like typhoid, you might just repeat every 12 hourly, or you will give one dose, watch what is the response, uh, and then take your decision on the repetition. But that is not possible every time. For example, in dengue cases, you give single dose and wait and watch, nothing happens. COVID cases also, my experience says single dose, usually nothing happens. Not even one registration happens. But when you start repeating it 3 times, then the registration happens. Even with dengue, I have seen the registration happening when you repeat the remedy. Malaria, good fever, repeat the remedy in the phase of apyrexia, observe the next paroxysm, what happens, then take your call. So again, here also flexibility is important. Understanding what is the susceptibility of the case, understanding what is the pathogenesis of the fever. Similarly, autoimmune diseases, I will normally want to give LM potency and give it once a day and observe it. So by and large, a little bit of uh, clinical trial needs to be done from your end, and take a call on what is the response. Just one dose will not sometimes elicit the needed response. Okay, one last important point in the follow-up regarding whether it is a fever, acute fever or chronic fever, especially in the acute fever, what is going to be very important is to understand the Hering's law of cure that needs to be followed in the follow-up. So I remember one case where the patient got better with fever. The fever, the peripheral symptoms, the associated symptoms got better, but the fever did not get better. And the next day, the patient started becoming drowsy. Then you're going in the wrong direction. The fever in an acute case, the fever has to go down first. The associated symptoms will improve later. So please be very mindful of the sequence in which the fever has to get better. Remember, fever means inflammation. So, and inflammatory markers. So that is very important to find out what are the inflammatory markers, and at the laboratory level and at the clinical level also, what are the inflammatory signs of inflammation. Fever being the first sign, and that should improve first. The general energy of the patient, the thirst, appetite should start becoming normal. Then the associated complaints. So I hope that gives things quite comprehensively about fever. We can take this up sometimes in more details at a more wider session. So if no more questions, then we end this stream. We'll put this up in our YouTube channel. Most of you can have a look at it even later, play it back later. If you have questions, please post it on the YouTube and or even Instagram. I'm not very familiar with Instagram communication, but feel free to do so. Yeah, I'll wait for another 30 seconds if there are any questions, else we will end. Any questions, any comments, suggestions, please feel free to put it. What can we do if the patient comes to us after taking paracetamol? That's exactly what I said, Dr. Sunita. We will have to unearth what is called as the original unmodified picture. How to unearth is that I had explained. Either you ask the symptoms before he took paracetamol, take the symptom what they are right now and see, you will find small traces of characteristic there in the fever. And if still nothing is found and the patient is not that serious condition, ask him to withhold paracetamol and see what symptoms come up. And physically examine the patient. Wealth of information comes through. Wealth of information. We don't examine the patient. Get investigations done. Investigations tell you a lot of things peculiar also. In a case with pneumonia, which sided affection will give you the site for the remedy, the lobe of affection in a pneumonia case, a high CRP level will tell you, a high neutrophil level will tell you it's a pyogenic fever, and you choose the remedy accordingly. So I hope that clarifies. The whole idea is you have to be after a characteristic. And this characteristic can be anywhere. Okay. So be open where the characteristic can be. Even in the reports, you can find something characteristic. The idea is you need to learn to look into it. That is very important. Okay. So we end this here. We meet after some more time. Please feel free to put your suggestions, comments on our channel and on Instagram. Do subscribe to our YouTube, Instagram handle. They're all there and we can keep in touch. Thank you so much. Wonderful talking to you all. Goodbye.